First of all, I would like to thank the International Association of Bioethics, and especially Manuel Ruiz de Chavez for the invitation to participate in this Congress. I want to congratulate Dr. Ruiz de Chavez for the organization of this Congress and also for his exemplary role at heading the Mexican National Bioethics Commission, which is a commission that has really generated enormous value in my country and that has been led by very, very major figures. I would only like to single out Dr. Guillermo Soberón, who's here with us in the audience, who also presided over this commission. And I would like also to take this opportunity to honor the memory of Dr. Manuel Velasco Suarez, who also served in that capacity. It is an additional great honor for me to share the stage with Tom Beauchamp and Norman Daniels, two of the truly towering figures in the field of bioethics. I'm not a bioethicist, but I have been in health policy positions with deep appreciation of the central role that bioethics in this expanded conception that we've heard from the previous two speakers can play. And that's why I have entitled my lecture, Ethical Foundations of Health Policy. And you will see that my remarks will follow very nicely, especially from what you just heard from Norman Daniels. What I want to discuss with all of you today is the use of an explicit ethical framework to guide a case of actual health system reform. As you have heard several times this morning, about 10 years ago, Mexico embarked on an ongoing structural reform intended to achieve universal health coverage, and that reform is still ongoing. The main message of my remarks today is that a clear ethical framework combined with technical excellence and political skill can deliver positive results for society. The Mexican reform was designed, implemented, and evaluated, making explicit use of what my colleague at the Harvard School of Public Health, Professor Michael Reich, has identified as the three pillars of public policy: the technical, the political, and the ethical pillars. The three are closely interrelated since they must act in harmony to support the complex edifice of reform. And let me very briefly discuss the use of the first two pillars to then really concentrate my presentation on the ethical component. I have to say that over these 10 years, because this reform has been evaluated repeatedly, there's a literature of more than 100 papers in peer-reviewed publications. So I'm just going to give a very, very brief overview, but anyone who's interested has access to a very, very voluminous literature on the reform I will discuss. So first, the technical pillar. The technical pillar of the reform was built on the intensive use of scientifically derived evidence. Much of this was derived from the local adoption of knowledge-related global public goods that were adapted to the specific circumstances of the Mexican context. Coupled with national data, these instruments revealed a critical deficiency, namely that the health system in Mexico, like in so many other developing countries, simply had not kept up with the pressures derived from a complex, protracted, and polarized epidemiologic transition. A transition whereby malnutrition, common infections, and reproductive health problems coexist with non-communicable diseases and injury. With half of its population uninsured in the year 2000, Mexico was facing an unacceptable paradox. Because today we know that health is a key factor in the fight against poverty. And yet, a large number of families were becoming impoverished because of healthcare expenditures. The reform was designed to correct this paradox by introducing a new public insurance scheme called Seguro Popular, or People's Health Insurance, and our Minister of Health, Dr. Mercedes Juan, alluded to that this morning. This innovative initiative is now protecting over 58 million Mexicans who had until now been excluded from conventional social insurance, employment-based social insurance. If we add to this figure those enrolled in social security institutions, and those with private health insurance, we can reasonably state that Mexico is on track to reach universal health coverage with financial protection. Furthermore, evidence can empower policymakers with convincing means to challenge the status quo and promote change. In this way, evidence also helps to build the second pillar of reform, the political pillar. In the Mexican case, this pillar demanded the development of a consensus among all stakeholders through active conciliation of interests between private and public actors, federal and local authorities, patient advocacy groups, trade unions, legislatures, and political parties. The consensus building process culminated in 2003 when the Mexican Congress approved a major legislative reform to establish a system of universal social protection in health to be operationalized through the Seguro Popular scheme. Needless to say, the construction of the political pillar does not end with the enactment of new laws, but must continue into the implementation phase, which is where we're now. To this effect, the new insurance scheme was deployed gradually over 8 years in order to allow for the necessary time to produce initial positive results that generated additional political acceptance. This is yet another example of how the technical and political pillars reinforce each other. Achieving consensus in the midst of a young democracy that was still groping its way into a new set of political rules was very much aided by ethical deliberation on the moral implications of the existing arrangements, which, as I mentioned before, excluded half of the population from effective social protection. So let me turn now to the heart of my conversation with you today, the ethical pillar of the reform. The starting premise is very clear. Every health system reflects a series of ethical assumptions. Consciously or unconsciously, explicitly or implicitly, these assumptions are expressed in the distribution of healthcare benefits and in the organization of institutions. Alongside the formulation of technical proposals and political strategies, every attempt to reform the health system should begin by asking which values it should promote. In this spirit, the Mexican reform was formulated and promoted on the basis of a guiding concept and a set of explicit values that are related to the idea that healthcare is not a commodity or a privilege, but a social right. The guiding concept underlying the Mexican reform of 2003 was the concept of the democratization of health. According to O'Donnell and Schmitter, the term democratization implies the application of the norms and procedures of citizenship to those institutions that have been governed by other principles such as coercive control, social tradition, judgment of specialists, or bureaucratic processes. The term citizen is associated with a range of rights and duties as defined within a constitution. In his seminal work, Class, Citizenship, and Social Development, Marshall recognizes three types of rights involved in the idea of citizenship: civil, political, and social rights, which in the English society were consolidated in the 18th, 19th, and 20th centuries, respectively. According to Marshall, citizenship culminates in the effective exercise of social rights. As a result of its democratization process, Mexico had made considerable progress in the exercise of political and civil rights. But it was clear that the next great challenge was to ameliorate inequalities by assuring the universal exercise of social rights, including the right to health care. And I think Normal has just gave a brilliant explication of the difference between the right to health and to health care. And I'm using the narrower concept of the right to health care. Now, this right was formally recognized by the Constitution in Mexico 2 decades ago, precisely when Dr. Guillermo Soberon was Minister of Health, and under his stewardship, the Congress amended the Constitution to recognize a right to health protection, which includes the right to health care. So while there was an explicit recognition of this right, in practice, not everyone was able to exercise that right in the same fashion. Half of the population, by virtue of their occupational status, enjoyed the protection of social insurance, because just like in the United States, access to insurance was a benefit of employment. The other half, however, the self-employed, the unemployed, and everyone who's out of the labor force, that half of the population, which back then were in 2000 were 50 million people, those 50 million were excluded from access to any form of health insurance. So the formal recognition of healthcare as a social right was already there when the reform started, but its actual implementation was only benefiting certain portions of the population. And what was lacking was the definition of the explicit entitlements that ensued from such a claim and the financial and organizational vehicles to translate them into effective health services for all. And again, although Norman and I work in the same institution now, we did not coordinate our presentations, but I think he has brilliantly explained how entitlements give this operational, actionable definition to the larger concept of the right to health care. So the definition of such entitlements in the recent Mexican reform was based on the adoption of 5 explicit values, which we called social inclusion, equality of opportunity, financial justice, individual autonomy, and social responsibility. Let me very briefly mention those, or explain those. Social inclusion is based on the premise that all human lives have the same value, and that health systems must represent instances where everybody, regardless of socioeconomic or labor market status, receives similar treatment for similar needs. Second, equal opportunity. And this is based on Amartya Sen's notion that inequality can be viewed in terms of differences either in actual achievement or in the freedom to achieve, which is the real opportunity that we have to accomplish what we value. Health services should help each generation to enter life with the same opportunities. In this sense, ensuring a basic common floor of health care for everyone has the same sense of justice as access to primary education. The third value, financial justice, means that individuals contribute to the health system according to their financial capacity and receive services according to their health needs. Out-of-pocket payments are unfair because they lead exactly to the opposite relationship. People contribute according to need, the sickest pay the most, and receive services according to financial capacity. That's why this reform aimed to eliminate out-of-pocket payments, because a fair health system is financed in such a way that services are free at the point of delivery, and a large enough risk pool is aggregated to facilitate 3 types of solidarity. Risk solidarity between the healthy and the sick, generational solidarity between the young and the old, and distributive solidarity between the wealthy and the poor. The fourth value, individual autonomy, means that every person enjoys the freedom to decide what is more convenient for him or her, a prerogative that the family assumes in the case of minors and of people who are limited in their capabilities to decide. And finally, social responsibility, the fifth value, places limits on the freedom proposed by the previous value. This is particularly important in the case of goods, such as health services, that exhibit what economists call externalities, that is to say, consequences to others of an individual's decisions. Thus, neglect to care for one's own health has effects upon other persons. And that's why, for example, in the Obama reform, the individual mandate is such an important part of the construction of that reform. So these 5 explicit values create the ethical foundation for the establishment of a system that provides, through the Seguro Popular, financial protection in health to all those Mexicans who had been excluded from the benefits of social insurance. The new scheme is mostly financed with public resources and a small family contribution that depends on the level of income and is waived for the poorest 40% of the population. Now, the most interesting aspect of the new financial formula is that its point of departure was the definition and costing of the specific entitlements that would give operational meaning to the right to health care enshrined in the Mexican Constitution. And again, Minister Mercedes Juan spoke about this, and Norman has really explained the underlying logic of this scheme. So, specifically, the guaranteed entitlements comprise two sets of interventions. First, a package of 285, what we call essential interventions for health conditions, and these are conditions of high incidence and relatively low cost, which account for more than 95% of the demand for services. That is one set of entitlements. And then second, there's a package of over 60 high-cost interventions that cover diseases with relatively low incidence, but particularly with very high, potentially catastrophic costs. And these now include treatment for HIV/AIDS, cancer in children, and cervical and breast cancer, among many others. So what I would like to discuss to end are the ethical implications of the use of a package of essential interventions, traditionally an instrument of technocratic approaches to healthcare, in a reform process that emphasizes equity and social justice. The packages of essential health services have been devised mostly as a priority-setting tool. In a context of limited resources, cost-effectiveness analysis has been used to identify those interventions that can provide the largest amount of benefits for the available public resources. And these interventions are usually targeted to the poor. In the Mexican reform, these packages did respond to the concerns for priority setting. However, their adoption was enriched through the incorporation of additional selection criteria, their use as a planning and quality assurance tool, and their extension to a universalistic conception of coverage based on the explicit definition of entitlements. So, first of all, we selected interventions making use of a broader set of criteria. We did use cost-effectiveness analysis, but we also added this criterion in the law of social acceptability, which, as Norman explained, needs to be operationalized, and I'd be glad maybe in the Q&A to deal more with that. But specifically, the idea of social acceptability was to make sure that those interventions that were defined as priority conform to norms of behavior of the health professions and to broader social preferences. A second innovation was the package of intervention provided a blueprint to then estimate the resources required in order to strengthen the health system and make coverage really effective. And then finally, the package was also used as a quality assurance tool designed to guarantee that all the necessary services are offered in accordance with standardized protocols. For the first time, the new law requires that every facility be accredited in order to participate in the insurance scheme, and accreditation is based precisely on having the required resources to provide the stipulated interventions. And finally, what I would like to stress the most is that the package has been used as an instrument for empowering people by making them aware of their entitlements. So in addition to the ethical dimensions, there's all these other uses of defining explicit entitlements. According to Brachet, the interpretation of health, or the transformation of healthcare into a real social right, requires above everything the definition of the set of health interventions that all citizens, regardless of their labor or socioeconomic status, should receive and can legally demand. The new Mexican law clearly states that Seguro Popular beneficiaries will have access to all the interventions included in both packages and to the respective drugs and other technologies. So, in summary, the Mexican model may be seen as an option to reconcile two extremes: the selective technocratic approach to the distribution of healthcare, which provides practical alternatives but pretends to be morally neutral, and the rights-based approach, which has a strong value foundation but has lacked operational support. Let me make one last comment on the global implications. I've explained this national case, but I think there are many global implications, particularly global implications of using a rights-based approach to guarantee universal access to healthcare. What I would like to stress is the fact that social rights are human rights, or rights that everybody holds as member of the human race. Therefore, the struggle to extend social rights, including the right to healthcare, transcends local legislations and the idea of national citizenship. This means that the demand for healthcare can come from anybody and not only from citizens of a particular country. This issue is particularly relevant given the level of migration that the world is witnessing. The implications of a rights-based approach are clear. It is unethical to limit access to health services on the basis of the migratory or legal status of any person. The human nature of the right to health care also implies that support from this claim can come from anywhere in the world. This opens an enormous field of action for international advocacy and global solidarity. In our turbulent world, health remains as one of the few truly universal aspirations. It therefore offers a concrete opportunity to reconcile national self-interest with international mutual interest. More today than ever, health is a bridge to peace, a source of shared security, a way to give globalization a human face. Let me finish by quoting the words of Michael Ignatieff. In the prestigious Macy Lectures delivered in Toronto in the year 2000, he stated the following, and I quote, "Rights are something more than dry, legalistic phrases, because they represent our attempt to give legal meaning to the values we care most about, dignity, equality, and respect. Rights have worked their way deep into our psyches. Rights are not just instruments of the law, they are expressions of our moral identity as a people. When we see justice done, we feel a deep emotion rise within us. That emotion is the longing to live in a fair world. Rights may be precise, legalistic, and dry, but they are the chief means by which human beings express this longing. And it is important to understand that this longing is a global phenomenon." End of quote. I would add that alongside the longing for justice, rights also generate a sense of belonging, since they point to our common identity as members of the human race. It has been a privilege for me to share with all of you our longing for and our belonging to the global cause of justice through health. Thank you very much.